So good afternoon, everyone. Like we know that type 2 diabetes till now, we are under impression that it is a chronic, progressive, irreversible disease. So like whether diabetes remission, is it myth or reality? So today we will be talking about this diabetes remission, and this will be the flow of our talk. First, we will discuss about the changing paradigm, defining remission. Then we will go on to see pathophysiology of remission, followed by what interventions we can do for remission, which type of patient to select, like who will remit, whether all patients are candidates or few selective group is the candidate, and post-remission management, what we should do. So to take things forward, Dr. Krishna, can you guide about the changing paradigm?
So, the way we have been taught and we have been treating diabetes, the way we have been taught and have been treating diabetes over the past century or so, it was always considered to be historically, it was considered to be an irreversible beta cell failure. And the goal was always damage limitation. It was mainly about glycemic control. And the success was defined based on whether the sugars were controlled or not. And this is the normal way a type 2 patient will progress. Initially, there would be a dietary restriction failure followed by oral medications, and the patient would be requiring insulin. And this is how a common type 2 progresses. But the new concept is that it is not about beta cell failure, or it is not about beta cell apoptosis. There is something else to that as well. It is more of about reversible metabolic stress, which is in the terms of lipotoxicity or the adipose tissue. So the old paradigm has been diabetes is a chronic progressive disease. Treatment is predominantly controlled based on the symptom control and on the medications. And the outcome was considered to be a beta cell decline and delayed complications. But what we are going to discuss today is, it is a condition of energy excess, predominantly because of increased adiposity. Treatment focuses on trying to remove the root causes, that is the ectopic fat, to restore the function. And the outcome would be restoration of normal glycemia and the freedom from medication. So with this background and with this stage, I would like to ask Rajbhai about how do you define remission?
So there are few fixed criteria of defining the remission. Like one is HbA1c criteria, there is for duration, and third is of the medication. So the glycemic threshold that we follow for the defining the remission is HbA1c should be less than 6.5. This is the cutoff. Like it is not below 5.7. It is just below 6.5. You can define remission, and it is defined not just by the number, but how it is achieved. So remission is valid regardless of the method, lifestyle, bariatric surgery, or temporary pharmacotherapy, provided the patients are off the medication for at least 3 months before measurement. So the washout period of 3 months is required to define the remission. Now, which terminology to use? Remission, reversal, cure, all are used interchangeably usually. But just as in cancer, remission implies a state of health that requires ongoing vigilance and surveillance rather than a permanent fix that allows for negligence. So the word cure should never be used as far as diabetes is concerned. And even with normal blood glucose, the underlying genetic susceptibility and biology persist, and hyperglycemia can return if metabolic stress reoccurs. So we have seen in the morning, like we cannot change our genes. So that genetic susceptibility will persist. So remission is not a finish line, it is a new state of maintenance. So, and like the patient is having HbA1c of less than 6.5. So to say patient is in remission, there should not be, like patient should not be on any glucose lowering medication. Then only you can say it is true remission. And if the patient is on GLP-1 receptor agonist or SGLT2 inhibitor, say some patients are on GLP-1 for weight loss and their HbA1c is 6, they should not be called as remission. The terminology that can be used is medication controlled. So in nutshell, this is the definition: HbA1c of less than 6.5 plus off medication, 3 months duration. This is the remission as per the guidelines. So now let's dwell into the mechanism of remission. So, Dr. Krishna, can you enlighten us about the mechanism?
Yes, so this is a novel concept being discussed widely over the last couple of, decades, I would say. It is based about a twin cycle. So currently we are talking about the two wheels of a cycle. One is the liver, the other one is the pancreas. Liver is a surrogate marker of insulin resistance, and pancreas is a surrogate marker of endogenous beta cell function or insulin production. And whenever any patient of diabetes, I'm talking about type 2 diabetes, is susceptible, given chronic positive energy balance in terms of high carbohydrate and high fat meals, there is going to be an energy or a lipid overflow. So as we know, as we discussed about MAFLD as well, but there is an increase in the intrahepatic fat, which in turn leads to a pathological intrahepatic fat, which in turn leads to hepatic level of insulin resistance. And this is when the fasting glucose starts rising in a patient of pre-diabetes or type 2 diabetes. Whenever the hepatic threshold is over, there is a spillage of the fat from the hepatic to the pancreatic tissue. But unlike the liver, the pancreas cannot hold a lot of fat because it is a small organ as compared to that of liver. And then steps in the insulin deficiency or the loss of the first phase of insulin response. So this is the basic pathophysiology. The lipotoxicity inside the pancreas causes the loss of the first phase of insulin response, and then a patient of type 2 diabetes emerges. So this is the twin cycle hypothesis, which has been discussed over the past couple of decades, I would say, and this is how it progresses. When we talk about remission, it is predominantly weight loss, and we are trying to extract the fat from the liver and the pancreas to target both the insulin resistance and the beta cell function or the insulin production as well. And this is how it happens. Whenever any patient undergoes significant weight loss, we'll discuss in the further slides how much weight loss. There is predominantly loss of the fat from the liver, wherein the fasting glucose starts to settle, followed by loss of the fat from the pancreas, wherein the insulin production goes on increasing. So this is the hypothesis which was proposed by Professor Roy Taylor, who is the, I would say, the stalwart of diabetes remission. So Harshbhai, this was the hypothesis, but do we have the data about this?
So the basic thing is, like when the ectopic fat increases at liver or at pancreas, the diabetes occurs. So we have to drain the ectopic fat. So as far as the evidence is concerned, this is the landmark trial, that is diabetes remission clinical trial, direct trial. It was done in adults from 20 to 65 years of age, and the criteria here is important. The type 2 diabetes duration was less than or equal to 6 years with BMI of 27 to 45 kg per meter square. They were given structured weight management program of total diet replacement. We will be discussing in subsequent slide. So here, as you can see, in 12 months, 46% remission was seen in intervention group, and at 24 months, the remission figure was 36%. So the clinical message is early type 2 diabetes is potentially reversible. Degree of weight loss determines remission probability. Timing and intensity matter, and remission is achievable in primary care.
Yes, so we talked about the BMI. I would like to focus on the BMI of the patients in the direct trial. But what about the lean phenotype? Apna Indian patients are lean phenotype of diabetes, where the BMI is not that high. So do we have data for that?
Yeah, so we have data for that also. Coming on to the retune study, achieving type 2 diabetes remission in patients with normal BMI. So like the thing to be noted is like 1 in 6 new type 2 diabetes cases, roughly 16%, have BMI which is less than 27 kg per meter square. So 27 was the cutoff in direct trial, and 1 in 6 will have BMI less than that. But type 2 diabetes is triggered when individuals' subcutaneous fat storage capacity is overwhelmed, and it leads to the ectopic fat accumulation. So the hidden ectopic fat in patients with normal BMI still will lead to the diabetes. Just go back, Krishna. So in retune study, the results were like 70% achieved sustained remission, 6.5% median weight loss was there. So only with 6.5% weight loss, the remission was achieved. It was triggered by modest weight loss, returning the liver fat to normal levels. And as liver fat was restored, subsequently, beta cell function was also restored. Next slide. So there is a theory of personal fat threshold. So when the personal fat threshold gets overwhelmed, the subcutaneous storage gets overwhelmed, it leads to the ectopic fat accumulation in liver, then in pancreas, leading to type 2 diabetes. And this is the reason why even the patients with lower BMI can achieve remission with the weight loss. So this is just the pictorial depiction. Like if the glass is full, anyhow it is going to overflow. The size doesn't matter. So this is the mechanistic insight. Disease driver is excess intra-organ fat, that is ectopic fat is the disease driver. And for remission, we need, like in obese individuals, at least 10% weight loss is required. And in just overweight individuals, remission can be achieved with the weight loss of around 6.5%. So now coming on to the interventions, Dr. Krishna.
Yes, so we talked about the pathophysiology. Moving on to interventions, predominantly divided into, so what we want is significant weight loss. So it can be surgical methods or non-surgical methods. So this is the bariatric surgery. There is a low-calorie diet and the low-carbohydrate diet. There is ample data on bariatric surgeries, which has been performed for many years now, wherein our own patients are becoming non-diabetic after the bariatric surgery. And this is the data. As high as 80% remission was there. Mechanism is both. One, of course, the weight loss. And because of the bariatric surgery, the intraintestinal hormonal milieu is also changed. So there is a change in the GIP and GLP as well, which is improving the glycemic status of the patient. What about the non-surgical interventions, Asbhai?
So, like we have already discussed the direct trial, just to emphasize that they have followed total diet replacement, and in the intervention group, they were following the diet with 850 kilocalorie per day. That was a formula-based diet, and they have followed for 12 to 20 weeks. Then 2 to 8 weeks of stepped reintroduction, plus structural support and rescue plan was used in this trial. And as you can see, the results, if the patient lost 5 to 10 kgs, like the remission rate was 29, 10 to 15 kgs, 60%, and more than 15 kgs, it was 86% in first year and 70% at 2 years. So basically the point is the remission is dose-response relationship, like the more the weight loss, more the chance of remission. And durability and challenge of maintenance is there, definitely. If the patient will regain the weight, they may lose the remission. That is why we are using the word remission and not reversal. So year 1, 46%, this is the total figure in the trial. And at year 2, the percentage of patients achieving remission was 36%. Now coming on to the rescue plan. So if there is weight regain, patient can again, we can try this relapse management with partial or total diet replacement. And 50% of the intervention participants required the rescue plan in the direct trial. Now coming on to the legacy effect. So even temporary remission can lead to the long-lasting protection. Like temporary state of less than 6.5 even can lead to the long-term beneficial effects. So remission is not all or nothing. Even a transient period of normoglycemia significantly reduces the 5-year risk of serious complications. So about pharmacotherapy.
So we discussed about the lifestyle, we discussed about the surgery, but what about the pharmacotherapy? Morning we have been discussing about the GLP-1 and GIP. So can patients on GLP-1 and GIP with HbA1c 6.5 called in remission? Currently, no. The guidelines based on 2021, no. But it is a changing regime. We need to understand that when HbA1c is less than 6.5, there is a reset of the physiological or the metabolic milieu. So in future, there may be a definition wherein from drug-free remission, there would be a medication-controlled remission is what we can expect in the future guidelines.
Now, which patient we should select? Like we cannot go on telling every patient that we will remit your diabetes. If the patient is having HbA1c of 14, we cannot assure that mati jase. Or if the patient is having BMI of 21, we cannot say we will remit your diabetes. So we should select the patient properly. If you will not select properly, there will be heterogeneous response. And if there is a stratified selection, you will get the good response. So there are few scoring system, there are few criterias which Dr. Krishna will enlighten us.
So basically, there are 3 scoring systems. These have been predominantly validated in bariatric surgery patients. It is the ABCD score, diabetes score, and diaram score. This can be easily got on the online calculators. The ABCD score includes age, BMI, C-peptide, and duration of diabetes. Diaram score includes age, HbA1c, medication use, and insulin use. And diabetes score, it's HbA1c, medication, and duration of diabetes. So to summarize these scores, what is a good patient whom we can offer remission? So this is the green signal here. Duration of diabetes less than 6 years. High C-peptide, medication, specifically no history of usage of insulin, and a score which is having high ABCD or a favorable diabetes score. So these are a subgroup of patients wherein we can consider remission. And the red flag here is longer duration of diabetes, low C-peptide, and the long-term insulin-dependent patients. So these are the patients who do not qualify for remission. So time matters, earlier the better. Better endogenous C-peptide reserve at the diagnosis, and we can of course use these scores to stratify our patients. So once we offer remission and remission has been achieved, how are we going to manage these patients?
So post-remission, like, see, basically we are afraid about the relapse. So relapse is all because of weight regain. Like weight loss will lead to remission, weight regain will lead to relapse. Because as you regain the weight, there will be return of ectopic fat leading to beta cell stress and relapse. So weight maintenance is the primary clinical objective, and the rescue protocol should be discussed with the patients, like dietary intervention, return to short-term partial diet replacement immediately, or pharmacotherapy if needed. So once in remission, you should not forget the patient. We should do continuous monitoring, and if required, these measures should be followed. Now coming on to drug-free trap, like whenever you stop medication, patient or even the treating physician can become complacent, कि भाई हवे मटी गયું છે diabetes, but that's not the case. We should like monitor the patient. And other thing is, many patients are on GLP-1 or SGLT2 inhibitors, and these medications have pleiotropic benefits such as cardiovascular protection, renal protection, so that may also increase in these patients. And as we discuss about legacy effect of the normoglycemia, there is a legacy effect of the previous hyperglycemia that can play out. So this is the hidden risk, and that is why vigilance is important for the vascular risk or microvascular damage. So prior periods of hyperglycemia can still cause cellular damage, and we should monitor such patients for these complications. So this is how you should do surveillance, measure HbA1c at least annually, monitor for rising fasting glucose. CV risk factors such as lipid profile, blood pressure should be assessed at least annually. Retinopathy, like continue standard screening intervals. If the patient is in remission, don't forget about the complication workup. We should do it as the patient, like as we will do in the patient with diabetes. And nephropathy workup also should be continued. So now coming on to diabetes management. Next slide.
Yes. So
yeah,
what is the paradigm of type 2 diabetes management in the current status? Yes, the common lifestyle intervention, which is the uppermost part, is gold standard. It is not going to go anywhere. After that, there is the SGLT2, GLP-1s, and the newer molecules, which is more of from glucocentric to organ protection centric. And then there is a small part which we are talking about, that is the precision focus, wherein we move on to the adiposity centric, wherein we try and decrease the fat in the patient, and wherein we can target remission. So this should be our pyramid of management of our type 2 diabetes patients. And these are the steps. We diagnose and screen. We put the patient on the scores. We look for what type of intervention can be given, implementation, and have a good rescue strategy, and lifelong monitoring in type 2 diabetes has to be considered.
So to summarize, remission is defined as HbA1c of less than 6.5 for more than or equal to 3 months of pharmacotherapy. It is achievable in early type 2 diabetes. Pathophysiology is reversible, reduction in hepatic and pancreatic fat. Beta cell stress is modifiable, insulin resistance is dynamic. Early intensive intervention for weight loss can lead to remission, and timing is the key variable. Shorter diabetes duration, higher remission probability. It delays progressive beta cell failure. So the clinical message is treat early, treat weight, treat the disease and not just the glucose.
So with this, what do you say? Remission myth છે કે reality?
It's a reality.
It's a reality. We have the evidence, we have the tools, we have the window. But do we have the will? આપણે આપણી ઓપીડીમાં કેટલા પેશન્ટને કહીએ કે તારું ડાયાબિટીસ મટાડી દેશું? નહીં. So this is what we are trying to discuss here. For decades we have been considering this to be a chronic progressive disease, but now we have got something deeper. It has to be considered more as a metabolic dysfunction, which is reversible, especially in earlier stages. And let's hope કે આપણે કાલના 30 પેશન્ટ જોઈએ એમાં એક કે બે પેશન્ટને we consider કે આને કદાચ remission થઈ શકે. With this we would like to conclude and hand over to the organizers. Thank you.